Welcome to Ask Dr. Mingle, the Q&A series from Mingle Health, answering your questions about quality programs and the transition to value-based care. I'm Kyle Breckel. I'm the digital marketing specialist here at Mingle Health, and I'll be hosting this episode along with Dr. Dan Mingle, founder and CEO of Mingle Health. Good morning, Dr. Mingle.
Good morning, Kyle, and good morning to all of you tuning in. It's great to see you again. I'm Dr. Dan Mingle, and I'm here to answer your questions to the best of my ability.
So last week, Dr. Mingle, we had a long discussion about digital strategy, and this week we're going to continue that discussion with some follow-up questions from listeners. So our first question today, Dr. Mingle, is from Anne, and Anne asks, you said that healthcare organizations should have a digital strategy and that a digital strategy includes documentation as structured data instead of textual data. But it seems that structured data is sometimes too limiting. Where's the balance point between the two?
Great question, Anne. I see that healthcare providers' key role is in translation. It's translation of a patient's complaints into structured medical concepts. It's translation of findings into structured terminology. And it's ultimately translation of that medical evidence into a management plan that fits the complaints and findings and that the patient can understand and manage. So we have that role of translation, and with every translation, there's always a risk as well of being wrong. So, and that probably leads us to that spot where the balance, where there's some unavoidable need for unstructured data in order to help us understand that uncertainty level. I think there's two places that unstructured data is required in healthcare documentation. First, in the chief complaint. This should be in the patient's words. The patient's complaint is not structured and shouldn't be. Capturing the complaint in the patient's words is valuable. It can help us identify when our initial translations are wrong. It can help us learn the range of concepts that patients mean when they make certain complaints. The second place is that we have to commit to a set of assumed translations of the complaints and findings, and come to a diagnosis and treatment plan. Now, every diagnosis and treatment plan is provisional to some extent. I mean, there's always a thread of doubt that perhaps I've gone down the wrong path. Sometimes it's extraordinarily the likelihood is extraordinarily high that I'm right, and sometimes it's extraordinarily low. And unstructured data can be the best way to express that. So that element of uncertainty can, sometimes it can be expressed in structured terminology, but may be best captured with a textual entry to give the needed color to the decisions made. I think the key to using unstructured entries in healthcare efficiently is to always think brevity and clarity. An excess of textual entry in healthcare data is inefficient, and a volume of text tends to hide or obscure important concepts and historical facts. Thanks, Anne. Great question.
Yeah, great question, Anne. So our second follow-up for you today, Dr. Mingle, is from Carol. Carol asks, compared to when I used to dictate all of my healthcare notes, the EHR seems clumsy. It seems more of a barrier to taking care of patients than a tool of efficiency. Is it even possible to grow to love my EHR?
Great question, Carol. I think you will love your EHR when it's a time saver and is helping you to better take care of your patients. Now, we've come a long way already in our digital evolution, but I think there's still a long way to go to optimally use our HRs to make healthcare more efficient and more effective, to actually help me or you enjoy the process of taking care of patients, and particularly the documentation side. Now, I think there are a few simple rules and concepts that will help make your use of your EHR more efficient. First, I think whoever collects the data should record it. The closer the documentation is to the source, the more accurate it will be. Every time data is handed off, the handoff introduces additional error. When the medical assistant or nurse collects the data, they should enter it into the record. Even clerical staff, usually the first contact with patients, can and should record things like the chief complaint in the patient's words with brevity and clarity. You can even capture data from the patient. All those forms you give them to fill out, they should go directly into the EHR. You should not transcribe their answers into the chart. They should just go there directly, and you should be demanding that of your patient portals to allow you to do that. You should never re-enter something that's already in the record. Redundant entries are extra work, and they introduce errors and confusion. They obscure the historical facts you want to be able to easily find. Now, our time in the medical record is better spent examining and correcting translations and assumptions rather than creating redundant entries. I'm excited about recent changes in coding guidelines that allow us to bill based on complexity and or time with the patient. It's a great transition after decades of rules that promoted higher volumes of documentation as a proxy for time and complexity. With the new coding rules, by saving documentation time per patient, we can see more patients and essentially be paid for writing less. I think important is that old carpenter saying that many of you have probably heard, measure twice, cut once. To me, that means ask again. Test the accuracy of your previous assumptions and the documentation that is structured in your chart. Change it only when you know or suspect that earlier assumptions were wrong. Use structured entry or brief and clear textual entry to explain your changes. So every visit to the patient, no matter who, whether it's your staff or you, or whether the patient is entering data into the portal, it should always test the accuracy of the old data and only correct the changes, not put in new. Now, the EHR is essentially a set of lists that reflects the health and healthcare related record of each of your patients and their visits. The more complete and the more accurate are those lists, the more time it will save you and the more rapidly you'll get to efficient and effective management plans. A couple of the key lists, certainly not a comprehensive list of the lists. Let's talk about the most important ones or the biggest ones, the problem list and the medication list. For problem lists, keep them clean. Resolve problems that have resolved. I see a lot of problem lists with old acute problems that just have never been taken off the list or demoted to an inactive status. Chronic problems should be reflected as still there. You should look at it and know what problems are still being treated. Those should have the specificity that is optimum for billing. So use the full ICD-10 code to get there to make sure HCC complexity, that's the hierarchical condition code complexity, is always reflected in the codes you choose when you're documenting your visit. Recurring problems should be reflected as a new instance of a previously used code with a new onset and ultimately end date. Unended recurring problems, unended acute problems are a common clutter in problem lists that I see. Acute resolved problems need to each have a beginning and an end. Changes in interpretation or the theory of the disease, your presumed diagnosis need to be reflected with entry of a new problem, retirement of the old, and a brief, possibly textual explanation of the change. Now, medication lists have a similar set of needs and dynamics as do problem lists. Keep them clean. A clean medication list is a time saver, and you do not have to re-record the medications if you have them right when you enter the chart. Every medication should be linked to one or more problems that it's addressing. End medications whose courses have ended. Chronic medications should be reflected as still in use. Recurring medications should be reflected as a new instance of a previously used med with a new onset and end date. Every acute medication needs to have a beginning and an end date. Changes in treatment need to be reflected by entry of a new medication, retirement of the old, and a brief, possibly textual explanation of the change. And I give you similar advice for all the other lists that can be in the EHR, like immunizations, allergies, family history, social history, etc. Keep them accurate, enter them once. Do not re-enter it if it's already there. Thanks. Great question. Oh, and if I can leave you with one final thought, let me just remind you, brevity and clarity are the most important driving concepts for all healthcare documentation. Let me tell you a story from my experience to illustrate these principles. When I first opened my private care practice in the 1980s, I stepped into the void created by the retirement of one doctor and the relocation of another from my small rural community. The retired doctor told me about his practice that sometimes demanded as many as 60 patient visits in a day. I knew from my contacts with his patients that despite the rapid pace the practice must have had, he was well liked, deeply respected, and provided great care. In my practice, all patients being new to me, I asked for a lot of old records. Many of the charts, including some of them sent to me by this retired physician, many of the charts were sent to me consisted of a pile of 3x5 file cards. Each card represented a visit. Each card epitomized brevity and clarity, containing typically name, date, chief complaint, diagnosis, and treatment, often nothing else. So it might be John Doe, May 13th, 1978, sore throat, strep throat, penicillin, 250, 4 times a day for 10 days. I was amazed and envious of the dynamic. When I started practice, a few decades of regulations designed to prevent fraud while documenting the complexity of each visit to justify our billing were adding words to each visit's documentation without adding content or quality. And I found as I gained experience that these elements of those note cards that I got from prior providers, that these were the data points for which I visually scanned each documentation in the later years. I rarely found the need to read all of the rest of the visit note, unless there was some kind of complexity, some kind of error I was assessing. It was usually just those elements. Who was it? When was it? What was the chief complaint? What was the diagnosis and how was it treated? Now, there was something that these short, brief notes lacked, and that was the contextual. It was the past medical history, the medication history, the social history, and this was best when I knew the patients and could be replaced there, but really didn't work well as patients were in more dynamic care environments where care might be handed off. So part of the enormous value I see in an EHR is how it allows us to get back to the efficiency represented by that old note style while giving the access to the data that we've seen in the newer notes to give us a better contextual richness that comes from the lists, and allowing us to be as efficient in our documentation as those doctors of old, while finding much more efficiently than the middle ground that those later notes gave us, by having that data live on permanently in those lists. So again, think brevity and clarity. Think how to use your EHR to understand the context of each patient without having to redocument every time. And remember, when you redocument something that's already in the chart, you're obscuring data. You're making it harder to find the things that are important. With those in mind, you can use your EHR effectively and you can grow to love it. So thanks everyone for the questions today. I want to be helpful. I want this to be useful to you. Don't hesitate to correct or supplement my answers. Share your experience. Ask your questions. We can be smarter together.